Good afternoon. Welcome to today's Grand Rounds presentation. As I usually do, I'll ask you to remember to sign the attendance record and also to fill out the program evaluations and give us any ideas that you might have in regards to future topics and future speakers. And in addition, I'll ask you to remember to drop off the audience response clickers when you leave the auditorium. Today's speaker is Dr. Ricardo Arbulu. Dr. Arbulu is board certified in internal medicine. In addition, he's board certified in infectious disease, and he comprises the infectious disease department at McFarland Clinic. He's here to discuss a topic that I think has tremendous clinical relevance, and it's urinary tract infections. A lot of us see these on nearly a daily basis, so we appreciate him coming today to discuss the state-of-the-art in management. So please join me in welcoming Dr. Arbulu.
Thank you, Dr. Halberg. Hi. Thank you all. Thank you for being here. Am I well heard in the back? Yeah? Okay. Thank you. All right. So whoever came up with the sandwiches, I really appreciate that. All right. So do we need to talk on UTI? Well, we actually need to be up to date with the guidelines, that's for sure. And I don't need to teach you guys how to treat UTIs. I think we do it pretty well. What we do need is to make sure we are sharpshooting, like I try to make that point with that picture, because there's a lot of reasons why we don't want to overdo antibiotics, as apparently is a national trend. So the objectives are in tune of that. This would be sort of a very public health oriented talk in that regard, and trying to link what we do in the daily practice with the impact of the society at large. I think a lot of medicine is being practiced that way, and the current guidelines reflect that kind of spirit. All right, we're going to talk about adults here. We're not going to talk about pregnant people. We're not going to talk about children. I will mention recommendations for pregnancy, and I'll specifically speak about that, but assume everybody else is non-pregnant. So, firstly, in order to navigate the literature and the guidelines and all that, we want to make sure everybody is aware of the current terminology. Because there's guidelines for some of this, and there's not guidelines for some of this. So these are the main UTI syndromes. Whenever you see bacteria in the urine or you suspect bacteria in the urine, you got to make sure you put the patient clinically in one of these boxes, okay? So you see the bacteria and you decide it is, let me show it here with the mouse. It is a contaminant, meaning that bacterium did not come from the patient's bladder, it did not come from the patient's kidney. It was just sitting on the skin of the introitus of the perineum or on the hands of the person who handled the specimen. So that would be a contaminant, right? As opposed to all the others, which are technically urinary tract infections. Asymptomatic bacteriuria is a concept that will be to death today. It is different from contamination, and it means, well, we recognize there's bacteria there in the bladder of the patient, but we think that the symptoms that the patient is having, if any symptoms, are not related to the presence of those bacteria. And then we get the spectrum of uncomplicated UTI and complicated UTI, which we'll define in a second, and a whole separate ballgame is catheter-associated UTI. Am I getting a lot of feedback with this microphone? Is that okay? Okay, cool. So what happened to plain old cystitis and pyelonephritis? I said every UTI needs to be put in these boxes. So certainly they are hidden inside these big boxes, okay? So you can get an uncomplicated cystitis, you can get an uncomplicated pyelonephritis, or you can get the complicated versions of them. But it's important that we make every effort to think through a UTI this way. First, as I said, this is how we're going to breeze through the literature, knowing these terms, and it helps to think through what to do with your patient. So this is exactly what I'm talking about. So complicated versus uncomplicated, the terms actually mean at risk for complication, right? So a patient that we classify as uncomplicated UTI, that actually means the risk for disaster is low, the risk that they get septic, or they die from this UTI is quite low, whereas complicated UTI, you definitely want to be aware of those, and your goals are primarily preventing that. So what are the goals in uncomplicated UTI? And the guidelines are very emphatic on that. Well, you obviously want to relieve the symptoms of the patient. You want to make them feel better, but you want to prevent collateral damage, which is, again, a concept that we'll present in a second. And in this day and age of waste in healthcare, a need for waste reduction, we need to avoid antibiotic waste and the expense of hospitalization. So uncomplicated and complicated UTI is not like just one quick definition. It's more like a spectrum. It's better understood this way. So to the left of the screen, you see the quintessential uncomplicated UTI. Everybody agrees that that's an uncomplicated UTI. If you get first of all, a woman, okay, she's otherwise healthy, pre-menopausal, okay, and non-pregnant. On the other hand, you get this guy who has a disastrous UTI. Not because, notice that there's no mention here on bugs at all. This is all about the host, right? So if the host is good, namely normal urinary tract over there, the lady with just symptoms of UTI, she's going to do fine. But if the host is bad to start with, you'll probably go into disaster. So what are those factors? Everybody recognizes if you have some urological abnormality, definitely you have a complicated UTI. So you've had neurogenic bladder, BPH, nephrolithiasis, urinary stents, to mention some. Renal transplantation is in that ballpark, though the evidence to manage it that way is not that strong, but definitely we want to be cautious on those patients. Sort of in the middle, but towards the complicated side, well, the fact of being male, that puts you in much more risk than if you are a female with a UTI. Immunosuppression, being elderly or frail, having diabetes or CKD, and we'll come back to this and see that that part gets a little blurry because we don't know how much this contributes individually to this problem of complicated UTI, whereas it's very clear in the other side, when guidelines and everybody defines uncomplicated UTI, that's pretty clear to everybody. Sort of in the middle, but towards the side of health here, the healthy postmenopausal women, that they have a little bit less of evidence supporting the management, but for the most part could be classified as uncomplicated. So this is what you want to prevent, okay? So Arnold is here to remind us about collateral damage, which was defined by Patterson. I'm not sure if this is the first time it was quoted in the literature, but this is a very important article in infection control, is the ecological adverse effects of antibiotic therapy. So what do we mean by ecological? The selection of drug-resistant organisms and the unwanted development of colonization with multidrug-resistant organisms. So basically, by giving an antibiotic, we are putting pressure on those bugs that are resistant to the antibiotic we're giving, and therefore, same logic like people are familiar with how C. diff develops, right? I mean, we give antibiotics that kill all the bugs on the intestine. C. diff has its name for a reason because it's hard to kill. It's difficile to kill. So same logic. The resistant organisms otherwise will be not killed and therefore thrive freely. So, uncomplicated UTI in women. Let's look at this as an opportunity to administer our antibiotics wisely. I'm going to ask you to vote on this one, please. And should be an easy case to diagnose, I believe. And I'm not going to ask you the diagnosis. So this is a 26-year-old woman from Ames, Iowa. And we'll come back to why is that important. Dysuria, urinary frequency. She has no vaginal discharge, no comorbidities. She's anxious. She's demanding an antibiotic. She had one UTI at age 20, and you don't know anything about that one. You get a dipstick, and indeed it shows leukocyte esterase and nitrates. She has no allergies. So the question is not the diagnosis, but somebody can yell the diagnosis? Thank you, Karen. I appreciate that. That was not staged. She really got it. So she has an uncomplicated UTI. Most precisely, she has an uncomplicated cystitis. Remember, the more precise we are, the better the guidelines can help us. So she has an uncomplicated cystitis. And you might have read stuff, but I'm more interested in knowing, and people will be more interested in knowing what you honestly would have done with this girl if she presented to your office. Can we vote? Do I need to press to? Okay, I guess yes. Oh. Ignore that one, okay? Help. All right, let's start over. Okay. And that check mark was misleading too, okay? So, okay, Tim, where are you? Should I just, there you go. Was that after the check mark? So people honestly prescribe a lot of Bactrim, which is in accordance to the guidelines. People also prescribe nitrofurantoin, which is the other first choice for this. So actually, the misleading check mark was because there's two correct answers here as far as the guidelines go. Bactrim and, I'm sorry using the brand name there, but Bactrim or Septra, and nitrofurantoin, aka Macrobid. There's people who would prescribe as quinolone, and I appreciate the honesty. So we're not pushing to acquire here. Now this is what, if we did this survey or this audience response thing at the national level, this is what we would get. This is data from 2002, but actually published in 2006, of what physicians are prescribing. And turns out that, well, it seems like we have a pretty good audience here, because people tend to prescribe quinolones for this situation more than the recommended treatments, which are nitrofurantoins or trimethoprim sulfamethoxazole. So, very important point to base the current recommendations. Why is this a great opportunity? Because it's a common reason to prescribe antibiotics to otherwise young females. So 8.6 million office visits, 84% of them are women. You do the math. In 2007, by age 32, half of the women would have experienced at least one UTI. And looks like the mouse pointer is on the way there. But this is to make the point that cystitis, please keep track of the term. Cystitis is much more common than pyelonephritis, and therefore, for the most part, this 8.6 million office visits are going to be situations that we don't really are concerned about, but I mean, things that are going to get better. And this slide makes the point that people do get better even on their own. You wouldn't think there's a placebo-controlled trial on treatment of UTI, but indeed there was more than one, and this one is fairly recent, in 2007, that compared treatment that is recommended in Europe. It's actually recommended in the United States, but it's just not available. Pivmeselinam, there's an extra E here, excuse me about that, given for 7 days, and they compare that to placebo. So just to understand this, we have two sets of outcomes here. We have the clinical cure and we have the bacteriological cure, and specifically we're looking at the bacteriological cure among those who were clinically cured. I hope that makes sense to people. And we're looking here at 8 to 10 days, and then these women were followed at 35 to 49 days. So if you see here, the blue represents the drug, and they were clinically cured in about 60% by 8 to 10 days. 20% of people, like, I mean, a fifth of these women got better receiving placebo as far as the symptom goes. Furthermore, if you look at those and look at the percentage of them who really got rid of the bug, that's what bacteriologic cure means, of course, they were over 50% spontaneously. These are healthy women. They're going to turn on their immune systems and get rid of the bugs. So this makes, before we continue, this makes an important point too. I mean, let's remember we're talking a lot about antibiotics, but we need to keep the broad mind that treating UTI is not only prescribing antibiotics, right? I do not have any slides on stuff like azo or phenazopyridine, but we need to do non-antibiotic interventions to alleviate the symptoms on things that in the specific case of azo, I didn't find any great evidence in favor of it. I found some attempts to compare it, but no real successful studies. But my point is we need to do interventions that have not proven to be very successful, but they may, and they are low risk, that everybody does, like drink water, do your azo, and stuff like that. But anyhow, back to the antibiotics. So we see that there is a microbiological cure with antibiotics, and there are microbiological cure without antibiotics. And this is verified also at the 35 to 49 days follow-up. And it's huge. How many people got better without getting an antibiotic? It's almost the same as with pivmecillinam, which was a good treatment anyway, and it's recommended. So I think that point is well made there. So further, people are concerned about if I don't treat my patient with cystitis, they're going to get pyelo. And if I don't give them an antibiotic, they come with pyelo. Well, the number needed to harm, okay, the number of patients you would need to not give an antibiotic to get one pyelo, it's reflected here. So approximately 1 in 200 and something, because this occurred at the same rate actually in the treatment arm here and in the non-treatment arm. So I've sort of correct my previous statement. Looks like pyelonephritis occurs at a low rate in treated and untreated people with cystitis. I think that's more accurate. What is the kind of pathophysiologic basis for this? Literally, when we look at E. coli, cystitis and pyelonephritis are two different animals. So there's an E. coli for cystitis, and there's an E. coli for pyelo. I didn't get a bad look from Dr. Milliman, so that's a good sign. There are genetic and antigenic differences among these bugs. So, and there's more data that reflects the same. This is just one study that shows how these patients do not complicate. On the other hand, we have great evidence on how to treat cystitis. And this slide is for you not to memorize, but to look at some numbers here. You see that consistently, both for bacterial and clinical cure, we have high rates of cure with pretty much whatever reasonable treatment we do, right? This is kind of an older study that looked at Bactrim for 7 days. People did get better on that. But on newer studies here, with 3 days, particularly this one is more relevant, 2007, people got better on 3 days too. And we're gonna put that together on the recommendations. This one, by the way, in the middle is kind of a cheat one because they excluded everybody who were resistant to the bug, so obviously their rate was good. They were 100%. But the point is made here that the cure rates are good with pretty much whatever we do. So all that to say, okay, you should not fear that much failing the treatment. Your patient is not going to get pyelo, and you play the odds, your patient is not going to get pyelo. Your patient is not going to die. We're talking about uncomplicated cystitis for people who just came in. So what you should fear Arnold, collateral damage, right? And we just spoke about that, and we will beat this to death. You want to know what's the consequence of using cephalosporins. Case control studies and studies that look at interventions like what happens if we pull out the cephalosporins from our hospital and stuff like that lead us to these conclusions. Use of cephalosporin has been linked to development of BRE, MRSA, ESBL, extended spectrum beta-lactamases, and multidrug-resistant versions of ugly gram-negative rods like Pseudomonas and Acinetobacter. We're talking in the hospital at large, not necessarily in the individual patient, but importantly for MRSA, and I'm sorry, that was a point I wanted to make with quinolones. Importantly for MRSA with quinolones, that can happen even during treatment. So even if you isolate, and it's not only exclusive to MRSA, but essentially staphylococcus. So if you get a staphylococcus in your urine and it's susceptible to Cipro, and for some reason you get a urine culture, I mean the guidelines are not to get a urine culture if you have a uncomplicated UTI, specifically an uncomplicated cystitis. You don't get a urine culture, you get a dipstick. But let's say you got a urine culture and you find out you have staph there, and the report says, oh, susceptible to Cipro. You give him the Cipro. Well, or her the Cipro. Just because of this, the patient may get better. They may even get bacteriological cure, but it is very likely that that Staphylococcus aureus is going to become resistant. And MRSA is promoted on that particular patient in isolates of the institution at large. So cephalosporins and quinolones are evil as far as collateral damage goes. They are the highest ranking collateral damage antibiotics. I wanted to make that point very clear. And that bases a lot of recommendations, because what we do is trying to be quinolone-sparers and to a certain degree cephalosporin-sparers for treating uncomplicated cystitis. Please keep track of the terms, I insist. We're talking about cystitis now, not pyelonephritis yet. So this graph shows you, and it's on purpose I've hidden the legend, so we'll try to guess here. So this shows you the cumulative change in resistance. So how much resistance you had back in 2000. It doesn't show you the absolute number, but how much it has increased, right? I hope that makes sense to people. So you see that there's an antibiotic here that has had a dramatically steep curve. You want to guess what that is? There we go. And this guy that is rock solid down here, nitrofurantoin. Now, scarily enough, Bactrim is also having sort of a steep curve, and we'll come back to that. And here the rest for you in the legend. So they're sort of in the middle, but this is what scares us. This is extremely relevant data from an article by Sanchez, which is the same one that previous graph is taken from, that shows several points. So these are annual rates of resistance of E. coli isolates to antimicrobials among outpatients from 2000 to 2010. And actually the article shows every single year, and I've just got rid of anywhere in between, and I'm comparing here 2000 to 2010. I want you to direct your attention to the last column, which makes the same point we were making on the previous slide. And as you notice, it's ranked by which antibiotic had the highest incremental resistance. So Cipro definitively aced that part. And concerningly enough, Bactrim, which is a recommended treatment, is having sort of a steep curve too. On the other hand, Macrobid, which you can tell I'm a big fan of, is really lower as far as incremental one. And that should be my pay here. Yeah, thanks, Nancy. So if we look at absolute numbers, you might be concerned too for the fact that nationally, well, ciprofloxacin is high, but also Bactrim is high. So we'll come back to the Bactrim issue. But I wanted to make the point again of this incremental change and already high rates of ciprofloxacin. Another point that can be made here is the ampicillin, which is also reflective of amoxicillin. This is a really lousy option for UTI, and the guidelines specifically tell you about that. And this is the summary of the recommendations. Actually, the next 3 slides summarize that recommendation. This is a little bit of a simplification of the algorithm that you find in the 2010 IDSA guidelines for treatment of uncomplicated cystitis, underlined there. And some of the information you'll find in the next slides too. So you encounter the patient. Everybody knows the lower urinary tract symptoms of dysuria, polyuria, urinary tenesmus. No fever, no flank pain, no other concern of pilo. Go ahead and use the algorithm. So your first decision after that is, well, obviously you want to check for allergies, you want to check for intolerances, you want to make sure the patient can pay for the treatment, and if so, be my guest and use one of the preferred treatments. So nitrofurantoin, aka macrobid, for 5 days. 5 days for that one. Bactrim for 3 days, and I wonder if people are familiar with this one. And it's terribly misspelled here. I apologize for that. There's an extra X here. Phosphomycin, just 1 dose. The actual, there's another antibiotic here, which is pivmecillinum, which I had mentioned before. It's just not available here in the United States, I mean. Okay, excuse me. So if we can't use this because of allergy, intolerance, availability, then we move on to the high collateral damage ones, right? Cipro, please, no more than 3 days. It has excellent rates of cure. Levofloxacin, no more than 3 days. Or one of the cephalosporins. Or amoxicillin, but with clavulanic, so augmenting, right? The only specific antibiotic that these guidelines caution us against is amoxicillin alone. Well, for the very same reason that we were pointing out here, it's bad to start with. Okay, it was bad back in 2000 with the previous guidelines. So there's caveats to this, and this is the other information that the real worthy algorithm has in the guidelines. So let's take a closer look at the preferred agents. Okay, macrobid. we said 5 days based on the studies that compare them head to head with quinolones actually, and with Bactrim as well. You do not want to do this if you have the slight doubt that your patient has pyelonephritis, because there is no absorption. It's just a urinary tract agent. It's just in your bladder. So you don't want to use that if you have any doubt in your head. With Bactrim or Septra, we have, well, 3 days, as we said. That's a quintessential 3 days treatment that is recommended. And you have this word of caution. So avoid if the local resistance is greater than 20%. Who knows what the local resistance is in McFarland Clinic? I guess Jo is here, but she's not allowed to answer. I see Dr. Killian pulling the pink paper, so if I had candy, I would throw to her. But you made a great point there, Dr. Killian, because you're looking at the hospital rates. That's the susceptibility, so it would be the inverse, right? 26%. Now, why is that information good but not perfect for what we want? Because that is the patient who gets admitted in the hospital who's sicker with pyelonephritis or urosepsis. So when we look at the local guidelines, we really want to look at McFarland, okay? And for your viewing pleasure, we do have the McFarland data right here, which is not yet in a pink card format, but I think it's a good idea to start doing that. Out of over 2,000 results that we got from October 2011 to 2012, we are still good with the trimethoprim sulfamethoxazole below 20%. The national average is bad at this point. And interestingly enough, this article that I've been quoting by Sanchez came out right after the guidelines were published saying, you know, caution if it's greater than 20%. It turns out that most people have it greater than 20% now. But we're still good, and this is how it should be done. You know, we should look at our local data to guide our treatment. And that's why, remember I showed you and I said it has some relevance that this woman is from Ames, Iowa? Well, because McFarland data reflects what Ames, Iowa has. So, Cipro, we're still good, but that doesn't mean we're going to get excited and prescribe Cipro, right? Because of the steep curve that we're seeing, and that I think we made the point before pretty well. So, this is the deal with this local resistance greater than 20%. We can still use it here. You want to get a history. Have they received Bactrim for other reasons before? So, if so, please do not give it. All right, so fosfomycin, we're really, anybody, can we do a count here who's ever prescribed this medication? Great, kudos to you. It's available. I mean, do you have trouble getting that, or? Okay. I just placed a call to Mary Greeley a couple of days ago to make sure, and they have available in Mary Greeley upon request. I am not sure about pharmacies around here, but it is in the United States. It's one dose. We're going to show the data on efficacy, but it's around the same ballpark, greater than 82%. So the only catch is similar to nitrofurantoin. So basically, if you are suspecting pyelonephritis, well, you should be pretty sure that this is not pyelonephritis. But anyhow, if there's any doubt in your head, Bactrim is your pick. Otherwise, the other two guys are good. And I'm emphasizing this one dose. The ER docs got excited about this, and I got a call about this when they were reading the guidelines, and they said, can we use this? And I think definitely we can. So more information for you, kind of in more depth, would be what adverse effects to consider. Macrobid does cause nausea, headache, and flatulence. It has both liver and kidney metabolism, so you don't want to use if your creatinine clearance is low. You don't want to use if there's pre-existing liver disease, because it increases side effects, of course, and decrease efficacy. There is, I'm going to jump to this one, there is this word out on the street that nitrofurantoin shouldn't be given for older people. And I looked at the data, and specifically there's data showing that it is okay. What is the problem with older people? Well, that they have high creatinines and they have liver disease. So if you select well your older people, you should be okay. The other catch is that, and that's not shown on any slide, is that the studies that that tested for efficacy included a little number of people greater than 65 years old. So you don't really know for sure how it works in that population empirically, but if you select an otherwise healthy person, it is likely to work for you. This is the cost, okay? Not too bad, I think. Bactrim gives a creatinine elevation that is technically not acute kidney injury, but rather a pseudo elevation of the creatinine. More concerning is hyperkalemia, which can be seen. It can give you bone marrow suppression and allergies. And fosfomycin, which we're getting acquainted with, causes diarrhea, nausea, and dyspepsia. But I said getting acquainted with because we don't prescribe it as much, but it's out there. Now, you may want to look at the cost before prescribing this one. It's one dose, though. Well, we talked about this, the second line agents. And we talked about this one. So, sort of summarizing locally, okay? Bactrim or Septra still okay as a quinolone-sparer agent, and again, we are talking about uncomplicated cystitis, okay? Ciprofloxacin, we still are good. Looks like people are probably reflecting what the audience response said earlier, that people are prescribing less quinolones and more Bactrim. We're still doing well, so keep the good job. Fosfomycin, be my guest to try it. And amoxicillin, well, our local data reflects what and this is ampicillin actually, but it's reflective of amoxicillin. Our local data reflect what it's out there elsewhere, that it's a lousy option. For the scholars out there, there is also this theoretical explanation that amoxicillin does not get rid of the bacterium in the introitus. So you may get cured from the episode of cystitis, but you get reinfected from the introitus. So 2 slides actually on uncomplicated pyelonephritis in women, since we beat to death uncomplicated cystitis. So let's work ourselves from there, right? Just to support you guys, these are the guidelines that we've been quoting, and they include a specific language on pyelonephritis that is uncomplicated in women, okay? Obstetricians, American College of Obstetricians and Gynecologists, Society of Obstetrics and Gynecologists of Canada. This is the big one from the Infectious Diseases Society of America and the European Society of Microbiology and Infectious Diseases and the European Association of Urology. All this have very coincident recommendations based, again, on evidence. Sorry for the wordy slide, but this kind of summarizes the treatment for acute uncomplicated pyelonephritis. And notice that here we don't mind the quinolones, okay? If you are saving them, save them for these cases. I hope people don't believe that every patient with pyelo needs to be put on the hospital. In fact, as you can see here, all these recommendations of uncomplicated pyelonephritis are ambulatory treatment, oral treatment, essentially. So fluoroquinolones, what is the duration of that? That's what you want to know, right? And Karen was asking me right before the talk, you know, when the 3 days, when the longer treatment. Okay, this is when you want to use your 7 days. And it's 7 days, it's not 14 days if you don't have an uncomplicated UTI. I'm sorry, if you don't have a complicated UTI, okay? So this is a woman who walks into your office, has the classic symptoms, she doesn't meet really criteria for admission. Of course, if they are PO intolerant, you want to put them in the hospital. And the duration of antibiotics still applies. It's going to be 7 days. Now, look at this. Bactrim has a little bit less of efficacy and evidence supporting it. That's why the recommendation ended up inflated to 14 days. But if you get this, if you read this article where this table comes from by Dr. Hutton, who's one of the names that you run most often when you read about UTIs and when you Google UTIs, is probably a too cautious thing to do. But if you want to stick to the guidelines, which I think is prudent, 14 days for Bactrim. So oral beta-lactams specific agents are really not listed, but basically we should be refraining from them, not the oral ones, okay? If we want to put the patient in the hospital, ceftriaxone, Rocephin is still okay. You're going to give them a shot, as you see here. Some of the patients in the studies were given also a shot of Rocephin concomitant to the oral antibiotics. That is okay. But it's not okay to give them a 7-day or 14-day course of oral antibiotics. Now, I virtually skipped the diagnostic part in cystitis, but I think I alluded to it that the guidelines said, okay, if you're suspecting an uncomplicated one, just get the dipstick. But in pyelonephritis, you cannot skip the culture, because if the patient ends up sicker later, you want to modify your therapy according to cultures appropriately. Which leads me to so what's the bacteriology? We've been talking about E. coli, and that is okay, because E. coli for cystitis, and sort of going back there, is 90% what causes your cystitis. There's all these other guys. When you move to pyelonephritis, it's still E. coli, but as we said before, it is not the same E. coli, right? It's a nephrogenic, if you wish, E. coli, one that is capable to infect the kidneys, as opposed to one that is designed to infect your bladder. But it's still mostly E. coli, and hence these recommendations that we swipe through are based on clinical data, but also on bacteriological cure, mostly for E. coli, and all this resistance that we showed you before for E. coli. Occasionally, you will run into the other players here, and that's where your culture comes into place, right? You want to modify your treatment. And this, I didn't have another chart for pyelonephritis, but it's essentially, I mean, if you plot it this way, this is obviously an oversimplification that I did from the data. It would show you around 80-something% of E. coli. So it's a little bit less, a little bit more variety when you get to the pyelonephritis, but still, you're good with treating the E. coli. Okay. We have a few minutes to go over asymptomatic bacteriuria, the other big opportunity here. Audience response, please, before you guys leave. 92-year-old female who's a nursing home resident. She has a history of a stroke, and she's hemiparetic due to that. Fermentation is perfect, though. She has some urinary incontinence, but can void voluntarily on time. So when she develops this, she does not have any symptoms, any dysuria, fever, chills, or back pain. But the nursing home got excited about, let's put this as a scenario, okay? There's a new caregiver there, and she was concerned about this urinary stress incontinence, and they said, let's check a culture. And they did, and they find 100 colonies of E. coli per milliliter. So here I'm going to ask you what the book says, not what you do. Could be the same probably. What is the best next step in management? You want to treat if she also has pyuria. You want to treat regardless of the presence of pyuria. You want to repeat the uric culture by straight catheterization to make sure and treat accordingly, or simply not treat. I think we need to click here. Boom. Excellent. All right. So some people would like to make sure, apparently, by straight cath. I mean, the spirit of that, I agree, but I'll tell you why that's not a great answer. And yeah, the pyuria, we're going to make a strong point that you don't care about the pyuria in this situation. So no treatment is the flat out straight answer that people are getting for the most part. Okay, real quick, I don't want to bore you with definitions, but one important point is that in order to differentiate asymptomatic bacteriuria from mere colonization, there is this thresholds, okay? So the more stringent criteria will be in people who are more likely to get contamination. I hope that makes sense. So if you get a clean catch specimen from a woman, probably that's going to be contaminated. It's not really clean, right? It's going to be contaminated with the introitus, with the perineum. So the definition, and this is mostly for research studies, okay? This is for us to understand what they've done on these research studies. They would define it as this level of 10 to the fifth, so that's 100,000, the number we're used to, CFUs per milliliter, but they require 2 samples because the first one could be a colonizer. So if we go to the other extreme, if we do a straight cath only on these people, then 10 to the second is enough and only 1 because we assume that came from the bladder. So this all comes down to the 50s and 40s, and this is one very classic study by Cass, who basically did not have Excel or PowerPoint at that time, so drew this by hand and threw pebbles apparently at this table or whatever it is. So what are we showing here? So we're plotting a first specimen of urine versus a second specimen of urine. If you're, and in this case it was done by straight cath, okay? These are 67 women that he just straight cath for fun because they didn't have symptoms to show what is asymptomatic bacteriuria. So basically, so here, first specimen, okay? So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 people plus 2 plus 2, 14 people had no bacteria in the first urine. So if we run a second specimen, well, obviously most of them won't have any bacteria, and some of them will have some. So you don't know what really, if these guys are, you suspect these guys are contaminants, right? So on the other hand, if you put a real high threshold, you'll see that you'll get a lot of concordance between the first one and the second one. So people came up with this threshold of 10 to the fifth, because above that, you get less or more concordance, put it positively, between the first and the second specimen. So we know there's bacteria that are multiplicating as opposed to just some transient bacteria that comes and goes, or some bacteria from the perineum that is causing likely this kind of contaminants. Hope that makes sense, because with these definitions in mind, we can look at the actual prevalence data of asymptomatic bacteriuria, and it's amazingly common in people. Obviously, women have more bacteria in their urine than men do, and that is because of the length of the urethra. Pre-menopausal women and men below age 55 have very low rates of asymptomatic bacteriuria, but when you get to greater than age 90, almost, and this, excuse me, I want to explain how these graphs are read. This is a box chart, so it gives you the lower, so these are pooled studies, right? So it gives you here would be the study that found the least or the smaller prevalence, and here's a study that found a greater prevalence. So this box reflects all the span in which results have fallen in many studies. And I plotted this based on multiple reference, but mostly from the asymptomatic bacteriuria guidelines that summarize this. So basically, estimates of asymptomatic bacteriuria in people above 90 are going to be 20% of the population at the very least, but almost half of the population at the most. We're looking at women. If we're looking at men, 20% of them. And it increases by age, is more frequent in women. I think those are the points made here. And it's very frequent. And these are people just living in the community doing otherwise well. So in men, why does it increase with age? Obviously, you get prostatic hypertrophy, which increases your post-void residual, and therefore the chances to keep the bacteria with you as opposed to clean them normally. The prostatic hypertrophy also leads to turbulent flow in the urethra, and eventually these men could have gotten procedures every now and then and may have seeded their prostate, and that's where this urine spills from. In women, the estrogen depletion is felt to induce pH changes that in turn increase the colonization of the introitus. So hence we're seeing huge rates or prevalences in older people. Now, if you look at institutionalized people, that goes totally crazy. So here are your people in the community, men and women, and here are your people in long-term care facilities. Obviously, they are older, but they have a lot of comorbidities too. So if we do a random specimen, some prevalence studies have shown that half of the people, and these are non-catheterized people, okay? They will have bacteria in their urine anyway. So we really want to be careful when to check that urine in response to what we do it, right? That's a main message here. And again, these are sort of intuitive. Why these people are getting all this bugs in their urine? Because they have a great incidence or prevalence of neurogenic bladder. They have fecal incontinence, so their perineum is all dirty and bacteria climb easily. They have decreased mobility, so that's another factor not to clean, and our wound nurse is shaking her head there. They have degree, the degree of functional impairment obviously correlates with the degree of asymptomatic bacteriuria. And we don't have a separate slide for diabetes, but diabetes, as most people know, increases your risk for asymptomatic bacteriuria. Okay, so we have no time, so I'll try to breeze through this. This shows the data on hemodialysis patients who tend to retain a little bit in their bladders too, and they have high rates. And this is just single point estimates. That's why it's not a box chart, but rather a column. Okay, this is very important, okay? And hope I catch most people before they take off. When you have a catheter, that's it. You're going to get bacteria in your urine, okay? And this is a plot based on the rate of incidence, which is estimated to be 2% to 7% per day. So if you leave the catheter by 21 days, you're going to have bacteria in your urine. And well, the next slides are bulky, and in the interest of time, I want to swipe through, but basically, take my word for granted and revise it in detail in the handout. There's a lot of data, randomized controlled trials that tell you people who are treated for asymptomatic bacteriuria, as we are defining here, do not get better outcomes, period. I mean, they don't die less, they don't have less true symptomatic UTIs. So therefore, and it has been studied on all these people, pre-menopausal women, pregnant women, diabetic women. The data shows that it only makes sense to check for a urine culture when there are no symptoms, when you're pregnant or when you're going to have a urologic procedure. Why? Well, again, empiric data shows that people don't do well. They get pyelo, they get bad outcomes when they are not screened and not treated. So hence, these groups we do want to. But on the others, there's a strong evidence that you do not want to screen, and the guidelines specifically speak about when not to do it. Pre-menopausal non-pregnant women, diabetic women. So there might be people in the audience that are tempted to do that. older adults even in the community, like our lady, I don't remember, she was on the case in the community or in a hospital, the case we presented, but in either or, she shouldn't be screened just for fun. Persons with a spinal cord injury, we show the high rates. Catheterized patients, it makes no sense just because it's universal on them. Arnold says you do not screen for them, okay? So what about the pyuria that some people picked up? I'm glad some did, so we can talk about it. It's pretty cool to notice that people don't only have bacteria in their urine, but they are responding to that. They are asymptomatic. They fulfill all our criteria, but there's a host response to it, and that's okay. Okay, I mean, it's technically an infection because an infection is defined as bacteria where they are not supposed to be on a sterile site, on a normally sterile site, with a host response. Okay, and asymptomatic bacteriuria clearly meets that criterion in most older adults older adult population, but we have empiric data that that is not about outcome from them. Probably 20 years from now, we're going to show that it's associated with something, but our data now has looked at mortality, has looked at incidence rates of symptomatic UTIs, etc. And the only associations we find is because these people were sicker than the others. That's the only confounder there that the studies have teased out by means of statistical analysis, of course. So anyhow, and the scholars may be interested in that is also reflected by presence of inflammatory cytokines. So these people do react to this bacteria, yet they do not cause any problem in them. So why are antibiotics prescribed for asymptomatic bacteriuria in institutionalized elderly people? This is a qualitative study. They sat down with people and talked with nurses and physicians, and I think this is intuitive for most people. I mean, there are concerns about what a symptom means on these people, and I agree. I mean, it's super hard to interview a very demented gentleman with 20 different medical problems, and at times we're tempted to say, okay, it's a UTI when we don't have a better answer. Just let me focus your attention on this one. The family and the patients themselves have some pressure, so they have some preconceptions on when they should get antibiotics, and it's our role to educate them. And you can read the others. So just one slide on catheter-associated UTI to tell you that the evidence is, I mean, there's a huge guideline, and it's all about prevention because we don't really know about treatment. We don't really have good data on that. We do know that we should make this diagnosis only if nothing else can explain the patient's sepsis or symptoms. They are attempting to recommend 7 days of treatment for those who get better promptly and 14 days for those who don't. But this is A3 level evidence, so that means the League of Justice sits down and discuss what is good for patients. It's not real evidence. So the Justice League, not the League of Justice. So the worst evidence of them all ranks in complicated UTI. Okay, so don't bother. I'll get back to you when a guideline comes out. There's a Canadian guideline that really is not helpful, and that is because we are looking at a spectrum here, as we said initially. We don't really have a good definition for complicated UTI. So call ID, I guess. I don't mean anybody's irresponsible, but this is a great motivator. And I really thought about putting this or not. Okay, I hope nobody takes offense, but it's put it on a positive way. Every single drop or every single tablet of Cipro that we give contributes to the flood. So let's be aware of that. Thank you.
Is analogous, the Bactrim is potentially quite evil and the macrobid not. I would reach for macrobid first. Do you have thoughts on that? Cost-wise, I gather it's not a big difference.
Cost-wise, have some cost data here. It's evil because you get the patients after they get the allergies, right? Is that what you're referring to?
And
yeah,
it's
I
a higher
agree.
incidence. It's like 10% versus much lower incidence with allergies.
I agree. I mean, that's factored in, I guess. So it would be interesting to know how, I mean, It's my subjective impression here in Ames, Iowa, that everybody's allergic to Bactrim, to tell you the truth. Back in Chicago, nobody was. So we probably need a study to tell us that. But here's the cost that you were asking about. Macrobid is more expensive, and it's a longer course. But the collateral damage and the, as we're showing here, this is what totally is a deal breaker for me, you know. Bactrim is looking more like a quinolone now in the sense that it's having a high steep rate of resistance, whereas nitrofurantoin is rock solid. So, but I agree. I mean, there are two valid options. So, you want to do whatever you feel better.
If no one else has another question, Derek.
Treating recurrent UTIs, prophylaxis, any recommendations on medications for prophylaxis?
I saw that comment. So in the guidelines for acute uncomplicated UTI, there are some recommendations on prevention of acute uncomplicated cystitis, okay? People who keep having that syndrome. For that situation, we have okay evidence, not the greatest, that cranberry juice may be useful. We certainly do not have any data on prescribing let me take it back. There is data that prescribing antibiotics continuously is effective, and there's also data that patient-initiated treatment, and I'm sure you're familiar with that, is recommended. Among those, in attention to a collateral damage, I would favor doing non-antibiotic approaches, maximize them, you know, and then pick the patient-initiated ones that I personally have done even for older patients, 65, 70-year-old ladies who are pretty aware of their symptoms. It is cystitis. They don't have diabetes. They don't have really bad incontinence, and you know they do well because they start their treatment, and that's, I think, a better way than just giving antibiotics forever. You know? Definitely, that's something you want to avoid. I hope that makes sense.
And then I got a question on Levaquin resistance versus Cipro resistance. Levaquin is a relatively benign drug as far as resistance is concerned. Am I right?
I wish I had the hard data. It's my impression that well, I mean, when you get resistance to one, you usually get resistance to the other. And again, I haven't looked at that recently, but it's just I look at cultures every day, so that's my impression. Now, you're right. If you're going to have one susceptible and one resistant, probably the Cipro is going to be resistant, and the Levaquin is going to be sensitive, just because it's broader and it's newer, right?
Resistance. As far as the generation of resistance, Levaquin not as bad?
As far as the resistance go, it shouldn't be that bad. And I should probably have some data from McFarland here, but yeah, it should be a little less, if anything. I agree with you. Joe is still here. Joe, you have an opinion on that? Oh, I have my card. There you go. There you go. That was the microbiology director, Mary Ridley. Thank you. Thank you, guys.